Hello everyone and good evening. Welcome to tonight's special webinar event, Incorporating Advanced Technologies into Your Robotic Assisted Bronchoscopy Procedures, sponsored by Ethicon. Tonight's speakers are Dr. Chris Manley, who is with Fox Chase Cancer Center, and Dr. Brian Schaller, who is with Stanford University School of Medicine. Before we begin, just a few reminders to anyone who is not new or familiar with SAB webinars. You have joined in a listen-only mode. You may ask your questions throughout the webinar by simply typing them in and submitting them in your question feature located on your control panel. At this time, we would like to thank Ethicon for being 2023 sponsored and for their continued support over the years. I'm going to hand it off to Dr. Chris Manley to get us started, and thank you all for joining.
Thank you to the SAB for organizing this event, and thank you to Ethicon for sponsoring it. Today I'm going to be speaking about complementary technologies for peripheral bronchoscopy. These are my disclosures. I'd like to start just by summarizing peripheral bronchoscopy in a nutshell, just a couple of quick slides. When we first started doing robotic bronchoscopy, we thought that all of the lesions we biopsied would have clear exophytic disease as we got out to the nodules themselves. We imagined with legacy technologies that our biopsy forceps and needles would follow the airways and easily glean tumor into the biopsy tools and give us a high diagnostic yield. What we found when we approached these lesions and were able to visualize them for the first time is that many are not exophytic disease. They have intact airway walls, and getting off access is really the best way to biopsy them. As we get closer to the lesions, the target window or angle of articulation increases. As you get closer, you can see, as I've drawn it here, for a 1 centimeter nodule at 5 millimeters off the front of it, you've got an angle of attack of 53 degrees. Whereas if you're 25 millimeters away from it, your angle is only about 16 degrees. So getting closer, having proximity gives you a wide window, but still doesn't guarantee a diagnostic biopsy. As you see in the first paper our group put out, the diagnostic yield can vary, but was certainly lower than we had hoped it would be, at 69 to 77%, depending on the true negatives. Now, maybe cancer detection rates can be explained by tool selection or lack of good biopsy tools, but anyone who's looked at the central biopsy literature for linear EBUS knows that biopsying lymph nodes has a very high diagnostic yield. Now, is it that the needle size or geometry is somehow different than the ones used in the periphery? Is it that the scope is somehow more stable? Or is that there's real-time visualization of what you're biopsying? I think that the procedure breaks down to 3 main parts. There's navigation, or getting out to the lesion. There's targeting, lining your instrument with the lesion. And then there's sampling. And I think by treating these as 3 different procedures, we can start to tease apart where there's still deficits and how we can make it. Now, near miss of nodules, despite good navigation, is because of things like CT body divergence, but also just simply being able to visualize the lesion as you get closer to it. I'll show this as an example of what's a quote unquote easy case. This is a central lesion off of the superior segment in the right lower lobe. You can see that there's an airway leading to it, but it's abutting the pulmonary artery. As we move out towards it, we can see the lesion, but we also see it's right next to the pulmonary artery. And so what to do? First, you need to remember that when you image something on radial ultrasound, the rebus probe is going to follow the curvature of the airway, but the needle may not. And so if you look on the left-hand side of the screen, that curved line is how I've drawn the radial EBUS probe. Now, if the lesion is on the outside of the curve, the tangential pass of the needle will probably hit it. But if the lesion's on the inside of the curve, it probably won't. And so just remember that with curved airways, there's imaging by radial ultrasound, but there's also striking the lesion with a more stiff FNA needle. So what I did in this case was identified where the pulmonary artery was, where it ended by radial, marked the lesion, and then made sure I extended my sheath of my needle past the PA so that I could biopsy it without causing a vascular injury. Now, small things like this can make big differences in your diagnostic yields, but still it's far from a foolproof scenario. So is 3D imaging the answer? Now you're going to hear from my colleague shortly on the ins and outs of 3D cone beam CT, but I'll show you on this quickly. We have a portable cone beam unit that we use, and for targeting lesions, it certainly improves safety. You can see this lesion next to the heart, between the heart and the liver, which we were able to localize and ensure the forceps were inside before even opening them. So you see, I moved the needle into position and the forceps into position, imaged before biopsying to ensure that I wasn't holding a piece of the pericardium or in danger of causing a liver laceration. But is there a better way that we can not just target lesions, but also sample them? So we've done some early work combining robotic bronchoscopy with confocal laser endomicroscopy. This is a needle-based probe. You can see in the top of the screen there, the probe is housed within a 19 gauge needle, and the probe acts like the stylet. When you drive out to the lesion, you can introduce your needle, and that needle houses the confocal microscopes. You can image with a depth of about 150 microns and see what the needle sees, see what's coming in front of you. If you don't see lesional tissue, you can make small adjustments and re-image. So in this picture, you can see that in the top of the screen on the CAT scan, there's a nodule, but it's surrounded by vessels. Then in the radial ultrasound picture, you see that nodule and it's surrounded by both pulmonary artery and pulmonary veins. Now by EM navigation, where I line up my targeting view, then gets you a picture you see in window D there, just benign bronchial cells, normal lung tissue. But when I move slightly off axis, you can see the thick clumping of pleomorphic cells. It shows that we're in the lesion. And so I think there's a difference between being in the geometric or 3D center of an area of interest and then actually being able to probe that tissue and evaluating where the lesion is specifically, or where the tumor cells may be lying. Here's another example. This is a lady with small cell lung cancer that I diagnosed in 2017 on the left side by linear EBUS. She was treated with chemo and radiation. She also had papillary thyroid cancer and bladder cancer. And so when she developed this new semicystic nodule, we needed to evaluate it because she had multiple primary cancers in the past. So I'll take you through here the robot driving, localization of the nodule, and then how we did the biopsy. After we do our registration, you can see I'm driving with my external sheath, approach the right middle lobe of the lung, and then switch over to drive the internal camera. You see there's the medial and lateral branches of the right middle lobe, and I'll actually flex into the lateral branch. And then in the sub-segments, I'll overflex so I can pop into that sub-segment and then correct to get back centralized within the airways. In the more inferior of the two branches ahead, I know that my nodule is below the horizon. You can see in the CT overlay video, the CT overlay view at the bottom of the screen. And I'll start to target the lesion. You can see there's no endobronchial component. And so I'm going to need to get my camera and working channel in line with the airway wall and get the needle to puncture through. You see I'm 14 millimeters away from the center of a 8 or so millimeter lesion. And I should be able to biopsy it without any difficulty. I introduce my needle, you can see under fluoro there, I've marked the nodule at an eccentric view by radial ultrasound. And so I put out the needle to where I think the nodule should be, where my EM nav is telling me I should be. And you can see I see early bronchial cells, and then some scant pleomorphic clumping there, but on the rapid on-site, just normal lung tissue. I make a small adjustment just off center of the lesion and introduce my needle again. And you can see again, it's about where it was marked on radial ultrasound. But this time when I introduce my needle, you see much more consistent clumping of this pleomorphic cells. There's very good stability in the robot. I think previous users of confocal imaging were frustrated by any sort of shake or movement in the camera. You see there's some cardiac motion there. You see that you can see the capillaries with some cells flying by, and then you see the dense pleomorphic clumping. And so pass 1, which was in line with my EM nav, gave me basically nothing, and pass 2, which showed pleomorphic clumping and confirmed malignancy. When we looked at our initial results, just the first 17 patients, we found that in 35% of the patients, we made readjustments based on the confocal imaging. No pneumothoraces, no significant bleeding, really didn't increase our case time very much. I'll show you our final results. We had 25 patients enrolled. The first 5 were run-in, and these are the final results for the manuscript. And what I'll show you, one, is the final diagnosis. Many of these are non-bronchocentric metastatic lesions. A lot of them are extremely vascular, like renal cell carcinoma, melanoma, carcinoids. And so it's not surprising that our rapid onset only had a sensitivity of 45%, and an overall diagnostic yield for this grouping of tumor types of about 80% when combining TBNA and biopsies. The NCLE imaging was extremely sensitive. Now, the incidence of malignancy was high, so it's hard to know what our specificity will be, but certainly we found lesional tissue, signal of pleomorphic clumping in almost every patient, 95% of patients. So I'll show you a final case example. There's a manuscript forthcoming that's going to be looking at granulomas. This is with Tess Kramer and UK Anema's group at Amsterdam Medical Center. But this is a case that was for a patient who had colonic adenocarcinoma, immigrated from China and had this PET-avid lesion. The team had a 3C cancer. They wanted to start therapy, and they needed us to rule out this lesion prior to starting. You see here, there's anthracotic pigment. There's some thick, dense, partially calcified lesions in the airway. And biopsies, the tissue was minimal. It really wasn't forthcoming. Very difficult to get a good quality needle pass through this dense tissue. When we flexed up into it, you can see a very small radial signal, very white. You see those calcifications there in the rebus. And then when we did our ultrasound, our confocal imaging, you can see that we can clearly see these granulomas, which matched with our transbronchial biopsies. So developing diagnostic criteria for benign lesions is important. The sensitivity and specificity of the device is going to depend on the criteria that we finally arrive on to discern the difference between malignant and benign lesions. But certainly you can make out lesional tissue when you're trying to localize your needle and maximize the quality of your needle passes. So in summation, navigation, targeting, and sampling, perfecting 3 procedures may require multiple solutions. Thank you.
Thanks so much for your presentation, Dr. Manley. We'll move over to Dr. Schaller.
There we go. Thank you so much for having me, to the SAB, to Ethicon, to sponsoring this event, and it's an honor to share the podium with Dr. Manley. That was a really great presentation, and especially your summary of our progress through peripheral bronchoscopy sort of encapsulated our journey as a field so well, and put things in sort of different perspectives than I sometimes usually think about them. So I'm going to talk about this in sort of a bi-directional fashion. One is robotic bronchoscopy with cone beam CT added, and the other one is cone beam CT to which one adds robotic bronchoscopy. And the reason why I'm sort of framing it in 2 different ways is because we all come at this question from different angles. Some of us started as cone beam users, and some of us started as robotic users. These are my conflicts of interest. This is, I think, the last time I will use a brand name in this talk. I will try to keep things generic and neutral. So, again, I don't think I can do this as elegantly as Dr. Manley, but this is sort of our progress through peripheral bronchoscopy over the years. And when I sort of came into pulmonology and first sort of heard about peripheral bronchoscopy when I was a resident. I think ENB was really, really the state of the art. But I little did I know how much literature pointed to the dissatisfactions and shortcomings of the technology. And so as I progressed through my training and into my career, I've sort of been, I think like the rest of us, asking this question of how can we do better. And when I started in my first, my current job now, our administration, we were not in a position to ask for a robotic platform. And so we had to look to other methods to try to improve what we were doing. And what we turned to was cone beam CT, because there were already facilities. There were rooms that weren't being used. There were C-arms that were kind of getting dusty. So what is cone beam CT? To those who are unfamiliar, this is really just a specialized C-arm capable of doing your usual live 2D fluoroscopy, 3D imaging with a very brief spin around the patient, usually somewhere in the range of 6 to 10 seconds, to create CT quality 3D reconstructions. And then lastly, augmented fluoroscopy, which is present on most or all fixed systems. And rather than sort of talking to you about what these are, I have a very quick video showing some of these steps. So this is the cone beam CT spin. This is the C-arm doing a 190-degree sweep around the patient. This is the CT scan that's generated from that sweep. And there's the nodule of interest. And you can see we're identifying the nodule and we're demarcating the nodule. And the purpose of this step is that then when you go into the room and step on your X-ray pedal, that image will be projected onto the screen. And this is a virtual representation of the nodule down here. So if you went and you took the patient off the table, this virtual nodule would stay there. Or if you gave the patient a pneumothorax, the nodule wouldn't move. But as long as you maintain stability, you do good high pressure ventilatory settings, breath holds, that nodule should ideally correspond to the location of the nodule in real life. And so this is just showing rotating the C-arm as we move the scope closer and as we move our biopsy instrument closer toward that augmented fluoroscopic target, which ideally should correspond to our actual target. And once you get there, you do another spin and you see where you wind up, and then you can always make adjustments based on that. And then very briefly, cone beam CT units are divided into fixed systems and mobile systems. What we just saw was a fixed system, and these have the benefits of faster image acquisition, better image quality, and integrated augmented fluoroscopy. The downsides are that they tend to be more expensive and they're fixed to a room, so they have a large footprint. In contrast, mobile systems are a lot more affordable, and as the name suggests, they're mobile. They can be moved from room to room, but they do have slower operation, lower image quality, and as of yet, none of the mobile systems has true integrated augmented fluoroscopy. So cone beam CT has been used for decades in IR, interventional cardiologists use it, dentistry has used it for a very, very long time. And it's very slowly been gaining favor in advanced bronchoscopy. And this is really for a lot of very important fundamental reasons. Firstly, it has superior imaging quality. It's pretty much the only tool that gives you true tool and lesion confirmation. And it's compatible with all bronchoscopic modalities. And that's something that we'll focus on in this talk. And then, lastly, cone beam CT really does have superior diagnostic yield compared to other technologies, or comparable diagnostic yield despite more challenging targets. If you look at papers that have lower yields on cone beam, a lot of times they're going after smaller targets under more challenging circumstances. So we started using cone beam CT. We used it with our flexible scopes, and the honeymoon was on. We went from doing about just under 50 cases of EMN guided peripheral bronchoscopy a year to over 150 in the following year. And we loved it. Our diagnostic yield was great. We were getting more referrals. We were able to diagnose patients earlier and send them on to definitive therapies, but things weren't perfect. So there are some distinct disadvantages that you learn over time, and that a lot of you probably have already realized to using cone beam CT in isolation. And one is the learning curve. This is a great paper from one of the groups in the Netherlands that publishes a lot of fantastic cone beam data, showing that there's a learning curve, as there is to everything, and that even past your first 100 or 150 cases, you keep on learning and you keep on improving your technique. And there are even bumps in the road as you get better and you take on more challenging cases. There's the learning curve adjusts again, and you have to get used to new techniques and doing things to get harder lesions. Time is a big disadvantage. Cone beam CT gives you the advantage to see just how off you are from your target. And so you end up adding more time, trying to readjust, trying to get into your nodule. And this was our median case time for our first 100 cases doing cone beam CT, 92 minutes. That's a long time. Radiation. One of the main criticisms of cone beam CT is that it uses a whole lot more ionizing radiation. 279 milligrays was the median for our cases. And this is air kerma level, 800, or dose area product, almost 9,000. Big problem if you're spending a lot of time in the room. And then lastly, pink tape. Lots of things have red tape. Cone beam CT has pink tape. And pink tape is all this pink tape that you have to use to stabilize your scope, keep things in place, keep your tool in place. Yeah, we have a mechanical arm to hold the scope, but what if it rotates? What if you need to hold it in flexion? What if you need to keep your biopsy instrument from slipping out because there's something weighing on it? And these are even more important in cone beam CT, where you spend time stepping out of the room during your spin, locating your target, marking it for augmented fluoroscopy. And really the pink tape is just sort of a commentary on the importance of stability, having stability during your procedures, having the bronchoscope not move around. So that's sort of my own journey through cone beam, leading to the integration of a robotic platform, but a lot of people can approach it from a different angle. You look at this natural trajectory moving up and up to robotic bronchoscopy with a superior diagnostic yield or a comparable diagnostic yield, but advantages to all the other platforms and modalities that have come before it. But as a lot of people who use robotic platforms know, over time, there are some disadvantages. As with all virtual navigation platforms, you're navigating off historical imaging, and you can get this right before your procedure. You can get this days before your procedure or 30 days before, and things may change. Things may even change once you get the patient on the table. As we all know, CT to body divergence is a real phenomenon, and it's a major challenge for peripheral bronchoscopy. There is no tool and lesion confirmation. So unless you're coupling your robot with other diagnostic modalities or other imaging modalities, you could be central, you could be adjacent, it could be a total miss, even if you're lined up with a yellow or green or blue ball. This is sort of maybe a controversial or unpleasant thing to bring up, but the reality is that diagnostic yield could be better. And while there's a whole range of diagnostic outcomes in different robotic bronchoscopy papers, just as there is with radiolibus and EMN platforms, it's important to look at the diagnostic criteria. It's important to look at follow-up. And lastly, it's important to look at what other adjunctive modalities are used with cone beam CT. And in looking things up and re-reviewing the robotic literature in preparation for this, I was surprised again to see how many of the really good papers, or some of the highest yield papers in robotic bronchoscopy, use adjunctive imaging modalities, even cone beam CT. And so are you really looking at the diagnostic yield of your robot, or are you looking at the diagnostic yield of the whole package of everything that you're doing? And then, diagnostic criteria is a really important thing to pay attention to as well. You could put a needle out, get normal bronchial cells, get a follow-up scan, and the target lesion goes away. That's great for the patient. That's an important outcome for the patient, but does it mean that your biopsy was diagnostic? So the merging of CBCT and robotic bronchoscopy is really about combining the two, the benefits of the two technologies, or allowing the benefits of one to overcome the shortcomings of the other. With cone beam CT, you have fantastic potential for diagnostic yield, you have tool and lesion confirmation, you have augmented fluoroscopic guidance, and you have near limitless compatibility. The robotic bronchoscopy platforms give you accessibility, they give you speed, they help improve your radiation safety by giving you that extra speed. And lastly, they provide, I think, an unparalleled degree of stability and control. And then, at the intersection of these two things is therapeutics. And I won't spend a lot of time talking about therapeutics. There's one slide later, but really success in therapeutics and the application of therapeutics kind of relies on having both of these things, having true visualization in the room and having the kind of stability and control that you need to target a nodule and deliver energy. So what do I mean by accessibility? Accessibility, I really think about as being getting into something and being able to use it, making the learning curve less intimidating, improving access to this technology among more people. Virtual roadmaps are imperfect, but they're familiar to bronchoscopists, and they're good at getting you really close to your goal. And robotic platforms and any EM or shape sensing navigational platform gives you a virtual roadmap to follow, and that's a great advantage. But as we all know, it's those last few centimeters or millimeters that really can make the difference between getting a diagnosis or not. Robotic platforms really help to lower that bar of entry for cone beam CT. You have less reliance on imaging during early navigation, and it gives you the ability to get closer to your target with virtual guidance. CBCT, in my mind, kind of carries you through to the home stretch. So it lets you to detect and compensate for navigational errors and really correctly traverse those last few centimeters or millimeters to your target in a rational fashion, not through as much guessing and checking or cloud biopsy or hoping you get something on rows and then adjusting, but actually through seeing where you are, through that tool and lesion confirmation. And really the whole goal is to take this picture over here and make it look like this. Apparently the width of the upright is about between 4 and 6.5 inches. That's not a lot of margin of error. And we know that when we're doing peripheral bronchoscopy, sometimes we're dealing with a similar factor. You have a very small distance to traverse, a very small gap to bridge between getting an answer and not getting an answer. So there's also the factor of time. Almost everyone likes shorter cases. Your anesthesiologist might not, because if you finish faster, they may got reassigned to another room. It could be a liver case, it could be a Whipple. You don't know. So sometimes it pays for your anesthesiologist to spend more time with you, but everyone else likes shorter cases. Cone beam and robotic bronchoscopy have unique equipment. They require their own additional setup, extra training. But peripheral bronchoscopy in general can be unpredictable. We have big targets that look easy that sometimes take longer than we expect, and sometimes it doesn't take us as long as we think to get to smaller, more challenging looking targets. But the numbers sort of don't lie in this case, and they really made us look back at our experience with cone beam and realize how much a robot helped us in our cases. When we were using just cone beam alone, all of our cases had a median time for our case was 92 minutes. It was 110 minutes for our non-diagnostic cases. The first 100 cases we did with the robot cut our times nearly in half, 58 minutes for all cases, 65 minutes for those non-diagnostic cases. And so much of this was improved time in that early navigation, having that roadmap get you close to your target, and then using cone beam CT and real-time imaging to guide you through to the home stretch. What about radiation? Radiation goes hand in hand with time. Radiation use is one of the major criticisms of cone beam CT. And the addition to robotic bronchoscopy substantially cuts down on radiation use. And this is in part because of just speeding up the case. There's less time you spend in the room where you might have your foot on the pedal, but also you're using your virtual navigation to get close to the target. You know you're not going to use it to get there 100%, but it's getting you in vicinity faster. So this was before we added a robotic platform. We were doing a median of 5 spins. I showed you these numbers before. And our first 100 cases after the robot, again, our numbers cut nearly in half, significantly fewer spins, significantly less radiation, and no significant difference in outcomes or diagnostic yield. And then, lastly, and sort of most importantly, our stability and control. Everyone likes a scope that's not moving around, except for maybe the people who make this pink tape. Scope stability is critical for cone beam CT. Your scope has to be hands-on during your spins, during your image analysis, when you're in the control room doing segmentation. And control over your fine movements is critical. As you get better and you go after harder targets, you really need to make even finer adjustments. And sometimes these adjustments are just not feasible with either your standard flexible scope or your flexible scope with an extended working channel. The robot provides unprecedented stability and control. And then, conversely, cone beam helps you make the most of robotic control. Real-time confirmation, looking and seeing what the tool to lesion relationship is, helps guide rational micro adjustments, not guessing, not taking a rough idea of where your target might be relative to your scope, but actually seeing my needle is medial and superior, my needle is lateral and posterior, and knowing in which direction you need to make a correction. And one of the things that I'm a little obsessed with cryobiopsy, which maybe speaks to my imprecision, but I love it. Stability and control is essential for doing cryobiopsy. And I put this picture here in particular because this is a target that you really don't want to have to navigate to more than once. And when you go out there with your regular flexible bronchoscope, before we had a robot and we had a balloon blocker, we were removing everything on block, having to navigate back up to this target again would have been a real pain. This is from a different case, but it just shows you what the contrasting situation is with a robot. Here's my fellow Prunjal doing a cryobiopsy through our robotic platform under cone beam. And we have our endobronchial image here and our image up here, and you can see when he pulls just how little the scope moves. And you can go in repeatedly, go back to your target, get multiple biopsies, and not have to worry about having to navigate out there again. And then lastly, peripheral therapeutics. Safe and peripheral therapeutics in bronchoscopy require precision, being able to target a lesion and avoid adjacent structures. stability, being able to stay where you are, have your scope stay put throughout the entirety of delivery of energy or whatever other modality you're using for ablation. And lastly, confirmation, being able to image during the procedure to ensure that you have adequate coverage. You don't want to leave the room, get your follow-up scan and find out that you probably have a big positive margin. And I would argue that, cone beam and robotic bronchoscopy best, if not exclusively, satisfy the above criteria. And as we get data on some of the trials that are ongoing and some of the trials that will be underway shortly, how this adds up. And then I just put this here, just sort of an example of a case that I don't think I could have done with cone beam alone, and I don't think I could have done with a robot alone. This was the patient's diagnostic CT. This was a 1 centimeter or 0.9 centimeter nodule in the right upper lobe. It was a nice quick induction, high pressure, high PEEP, low FiO2, all the navigational, anesthetic and ventilatory parameters, a nice quick 5-minute nav. And here's our first spin. Here's our nodule wedged way down there. Now, if I had done a nav on this alone with a robot and had no confirmation, I don't think I would have been able to target this area. It's completely swallowed atelectasis. When you have cone beam imaging and you can see, hey, here's the border of my nodule, I see it right down there, you can make your rational adjustments, you can do tool and lesion confirmation, you can make sure you don't go too far with your needle. This turned out to be adenocarcinoma, and I think this is a case that I don't think would have been feasible, at least for me, without both of these technologies combined. And then I put this up just sort of to wrap up at, showing how much of a difference adding a robot made. Our cases got faster, our radiation doses got better, we got more comfortable doing more challenging cases, and we were able to offer our services to more people. So cone beam was a great benefit to our service and to the service we were able to provide our patients, and the addition of a robot to cone beam platform helped us even further in bringing care to more folks. So what's next? What do we need next? We really need more published data. We need, really all we have now are small single-arm series demonstrating efficacy and safety. We don't have any comparative data. There's one study registered on clinicaltrials.gov right now, looking at EMN and cone beam versus shape sensing, robotic bronchoscopy and cone beam. It'll be interesting to see what the outcomes are there. We don't know if there are any meaningful differences between robotic platforms. And we don't know how new arrivals, whether different robotic platforms, different navigational technologies or imaging modalities will fit into what we're doing currently. And then lastly, we need patience and open-mindedness. And this was something that I think I had to overcome and my whole group had to overcome. And fortunately, we're a friendly group and we love working with each other. But whether you're a cone beam user and you're looking into getting into robotics, or you're a robotic user and you're looking to get into cone beam, you need patience with your administration to argue for your needs and lobby for what you think would be best for your patients and your practice. Patience with your staff in learning a new technology, learning a new setup, getting used to new equipment with your tools as you figure out all their little intricacies and shortcomings, and then also with your own stubborn self as you get more and more competitive with yourself as you add new technologies into your armamentarium. But I really think it's worth it, and I think both of these technologies have made peripheral bronchoscopy a much more gratifying experience. So in summary, cone beam CT and robotic bronchoscopy really offer their own unique advantages in peripheral bronchoscopy. Adding cone beam CT to robotics can improve your diagnostic yield through advanced imaging, added guidance by means of augmented fluoroscopy, and tool and lesion confirmation, really knowing what the relationship is between your tool and your target. Adding robotic assisted bronchoscopy to cone beam, conversely, can improve accessibility to cone beam CT. It can cut down on your procedure times and radiation use, and it really gives you an unprecedented degree of stability and control. And then lastly, as we move into the future of therapeutics, the merger of cone beam CT and robotics will really be, I think, essential to success. One slide as a shameless plug, we offer a cone beam CT and advanced bronchoscopy course. We had our first course last year. Fantastic speakers, Mike Pritchett, Brian Husta, and Krish Badra came in, and it was a really fun event, and it was great meeting people and learning how other people do their practice. And we're hoping to have our second course this year in March 2024. So this is a quick save the date, and I hope some of you can make it out there. So thank you for having me. This is the rest of our team. This is the number of people it takes to deploy a Bono Y stent, apparently. Feel free to call, email, text me. Love to talk to anyone. And thank you for your time.
Thank you, Doctors Shaler and Manley, for a wonderful presentation. We will get started with some questions. And please, everyone, if you have any questions, remember to type them in and submit them into the question or chat feature, and we will get to them.
While we're waiting for some questions to come in, Dr. Manley, did you maybe want to make a comment on Dr. Schaler's presentation? And I'll maybe ask a flip as well. Any questions that you have for each other and how you might look in terms of your perspectives and partnerships in your own way?
Yes, thank you. First, really wonderful presentation. Really appreciate low-tech solutions. Love your use of the pink tape. My question really would be, when you began your cone beam practice, were you still using EM-NAV to navigate out to the lesion, or were you comfortable just using an extended working channel without an EM signal to localize the lesion and then secure your catheter and do the biopsy?
Thank you first. And we were using, for our first maybe 6 or 8 cases, we used Super D. And we found that it didn't offer a whole lot on top of just using a flexible scope, which I think speaks even more to the benefit of adding the robot being more than just having quick navigate, early navigation. We quickly dropped the MN and just used either a thin scope, ultra thin scope, or a regular scope and extended working channel. That was a quick change in what we did. We also very quickly dropped radiolevus from the equation because we were putting a tool out or just getting close to doing a spin.
Yeah. And when you added cryobiopsies, is the benefit in your mind that it's sort of a circumferential or perpendicular sort of sampling as opposed to a needle pathway? What is it about cryo that gives you additional yield?
I don't know. That's a really good question. I wish I knew. I think part of it is that and this sounds sort of bad, but you don't have to be as precise. You don't have to be in that inner third, or you can be adjacent to a lesion and still probably pull out some of the side of it. So I think it at least for me, it probably helps me overcome some of my shortcomings in getting right into the center of a lesion. I like it for ground glass targets and subsolid things where I'm worried I'm not going to scoop up enough cells with a needle. And I think the other, I have a question for you about mobile cone beam use and how you've incorporated that, but I'm sure you've had cases where you're using imaging and you can put your first needle out and it makes a little bit of a mess and you have trouble getting a crisp image again. And so I sort of felt over time that if that was going to happen, I'd rather at least have a big piece and have my first, if I make a bloody mess, at least it's with a cryo probe.
Yeah, I agree. I think that peripheral biopsies aren't that much different from doing arterial blood gases. You get it right away, you got it. If you're kind of poking around for a while, the likelihood of success, there's sort of a diminishing return with every minute you spend sampling. And so I do think there are some lesions where you are in the center of, carcinoids or renal cell carcinomas are ones that come to mind where your rapid onsite is just blood. And what we if we had the suspicion for that, if they had a previous history of nephrectomy or renal cell, these very vascular lesions, if it was all blood on the slide, we took that as sort of a positive predictor that we were in the lesion. The limiting factor, I think, of needles is that it's sort of capillary action. So you fill fill your sheath with lots and lots of blood. I think getting good bites, especially for sort of the renal cells, which are just lots of, when you see them under the microscope, strings of blood vessels with, adherent cancer cells as opposed to the other way around. And I think that sampling for different kinds of lesions is extremely challenging. I think for ground glass opacities, people will say you can't see them on radial ultrasound. I think you can. There's Tim Merg who put me on to the sort of blizzard sign when looking with radial. as opposed to just a sort of snowy sign of normal lung. I also think for cone beam, you know, we use a portable cone beam, so the resolution is not quite as refined as a fixed unit, but we do a couple of things to improve it. One, we induce the patients with a low FiO2, so there's still some nitrogen in their alveoli, just reduces the amount of atelectasis throughout the case. And that was really speaking to our anesthesia colleagues about being comfortable not pre-oxygenating for induction. Because I think you can do all the recruitment maneuvers you want to, but if your anesthesia team has washed out all of their nitrogen, there's just not a lot you can do with positive pressure, right? You need the alveoli to stay a little filled with like an inert gas. And so we do a low FiO2, no pre-oxygenation, and then also what I've found is when I drive, I keep the CAT scan up in the room. I've got a coronal picture up, I've got the axials. I match the coronal to my regular fluoro, make sure that where my robotic sheath and camera are located makes sense compared to my coronal CT scan that I have up in the room. And then when I do my spin, I start looking for other landmarks. If you can't quite see the nodule, if the lesion's getting atelectatic, well, is it near the top of the diaphragm? Is it near, if you're in the right upper lobe, is it near the copula of the lung? Is it, if you're on the left side, how far is it from the aortic arch? And so you start looking for all sorts of landmarks that can kind of lead you to where you need to be. And even if you don't have augmented fluoro, you're kind of navigate almost, you know, like sailors navigating by the stars. You're using whatever you can to give you reference points. I think when it comes to adding confocal, you know, it's sort of like rose that's always turned on, right? It's a continuous slide, it's a live slide. And so when you're probing some of these areas, one of the things I found most useful is I started to recognize bronchial cells. So if you're doing biopsies and you're just shaving bronchial cells off the airway wall and you're making slides and your cytologist says, oh, we have nothing. You know, I started asking, what do you have? What's nothing? And they go, oh, well, they're just denuded bronchial cells. We see cilia, whatever. Well, then I know I need to turn into the airway wall and have a more aggressive angle so I can punch my needle through. It's just scaving down the side. But when I'm using confocal, I'm looking through the front of the needle and I can see bronchial cells. I can see smooth muscle. So if I'm just scaving off down the side of an airway, I know I need to turn into it, have a more aggressive approach, pop through, reintroduce my confocal microscope. Then I can see lung parenchyma, see vessels, see capillaries, and then try and find lesion. And so you're sort of interrogating the tissue as you're trying to move from navigation to targeting to biopsy. I find that you're sort of negotiating with the lung, you're negotiating with the airways, with the tissue. You're trying to get as close as you can to complete each of those three procedures.
That scenario that you describe, and I think the case that you showed is such a great example of it, of having that, you know, having the additional confocal information, seeing bronchial cells, knowing you have to turn into the wall. I think about those cases where you know from your cone beam scan, or you know from your diagnostic CT scan that you're just adjacent. You're never going to have that head-on view looking down the airway wall and go through a carina or eventually go out into the nodule. And you lose your view, you have some blood, you have some mucus or whatever it is. And it sounds like, you know, one of the, I could see having that extra confocal endomicroscopy view to know, I put my tool out, I can't see where I am. Am I still in the airway? Am I out in the parenchyma? Have you noticed, or is there a different signal when you are still in the airway versus when you're in normal lung that at least tells you that you've made it through and you're getting closer?
It's interesting. There's a couple of artifacts that we found. There's a non-contact artifact where there's this mosaic sort of pattern on the when you don't have apposition of the microscope to tissue. You don't just get air bubbles. You actually get this little mosaic artifact. Sometimes you actually see that in very necrotic tumors because the elasticity of the tissue is what causes the apposition. So you put a little bit of forward pressure on your microscope fiber, inside the needle to get good apposition and good imaging. But if it's a very necrotic tumor, or if you're in an airway where you're still traveling down the lumen, you're never going to get apposition. If you keep pushing, everything's going to just be moving in front of you. So getting rid of that non-contact artifact is helpful, because you know at least you've got apposition against tissue with some elasticity that's pushing back towards you. And then the other part is if you have your microscope needs to be a couple of millimeters outside of your needle before it'll image. So you slide your microscope back to do your puncture. But if your needle's sort of stuck, you feel like it's stuck in a carina, you can sort of cheat your fiber up and start peeking at what you're stuck on. You sort of start peeking and trying to see the smooth muscle, which is very striated compared to the lung parenchyma or the bronchial cells. And so we learn as we go. I think that the initial criteria for being in a lesion, excuse me, were just three simple things. Do you see clumping of cells? Are they pleomorphic? Is there sort of bizarre size? Are they sort of dark clusters? If these were there, then you sort of said this is a lesion. Is it malignant, non-malignant? Now, you know, this my colleagues in Amsterdam who will be releasing a paper on granulomas, you know, there are benign criteria very different from the malignant ones. And so I think that our specificity will start to increase to get more experience.
Do you feel like there are cases where you have such confidence in what you're seeing on microscopy, that on endomicroscopy, that a non-diagnostic result or a non-diagnostic rose is enough to, you know, pick up the phone and call your oncologist or call your surgeon and say, hey, I'm really certain about this?
It's impossible to convince anyone of that. I think there are some, you know, some of the carcinoids that we sampled that look very bizarre. You know, the cells look so different from what we would see otherwise. You know, adenocarcinoma, especially if you're using, we try not to use saline during these cases, but even from your experience in Rose, I'm sure your cytologist has said, you know, you've denuded the cilia off these bronchial cells, you plump them up with some saline, they just look like they could be adenocarcinoma. They look very atypical. So there's, you know, if you're looking at a lipidic adeno, you know, you've got like AAH that's like turned into minimally invasive adenocarcinoma. It's very lipidic, very normal looking. That's going to be hard to call purely on a black and white image without any kind of stain. I think that there's some that are going to look extremely bizarre. I think it's going to be hard to convince an oncologist without all of the stains that they need. Potentially for a surgical resection or something like that, I think it could be helpful. But I think the next step in some of these imaging technologies is, if we want to start delivering drugs at the time of biopsy, you know, your cytopathologist can tell you they think it's an adeno. They might even tell you they think, you know, you've got a primary lung maybe, but will they really, if you say, okay, we got non-small cell, okay, I think it's adeno. Is it lung adeno or colon adeno? Is it prostate adeno? Are you going to deliver a PD-1? Are they an EGFR mutant? So until there's a one-size-fits-all drug, we need to know more about the tumor type at the time of diagnosis if we're going to start doing intratumoral injections. And so if there's imaging modalities that can, you know, through either antibody staining or fluorescence, tell us more about the tissue type, I think that is when there'll be real value adds in making treatment decisions in real time.
Thank you both. We do have a couple of questions from the audience. The first one for Dr. Schaller, do you still use Rose with cryo?
I don't use Rose with anything. I used to use Rose we used to do Rose for all of our cases. I don't use Rose ever anymore. A lot of it just had to do with the fact that and we look back at it, it didn't make a difference in our diagnostic yield. And there was a signal when we looked at our data that actually hurt diagnostic yield. So what we found was when we were doing our biopsies with real-time visualization and we had tool and lesion confirmation, or we didn't have tool and lesion confirmation, even worse, and we hammered and hammered and hammered at a nodule with needles and, to get cytology specimens, we made a mess. The nodule got, obscured in perilesional hemorrhage eventually. Our 8th pass was negative on Rose, and now we couldn't see the nodule to put forceps in or to put a cryoprobe in. And this is, also I think goes back to Dr. Manley's question about, like choosing, using cryo. If I could just place a cryoprobe in the center of a lesion, get 3 samples and be done, looking at our data, the chances that those our diagnostic yield on cases when we do that versus cases when we start with a needle or cases when we used to use Rose are the same or better. And a lot of that just really has to do with the fact that Rose is not reliable. It's not in the end, it's not the final answer. And we don't have this data yet, but I would, I think in the next couple of years we'll have that paper hopefully about tool and lesion, the value of tool and lesion. And I am willing to bet that tool and lesion is at least as valuable as Rose. And if you're seeing tool and lesion and you're not getting it on Rose, then it's probably not, we've all done EBIS cases where we're in the lymph node on our 12th pass and our Rose is still negative. So I don't use Rose anymore at all. You can use cryo with Rose, you can do a touch prep.
Great, thank you for your feedback and perspective. One additional question came in for Dr. Schaller. Can you describe your learning curve for using cone beam with Monarch?
It's hard because we started off with, we got used to cone beam first just by itself. If I could step out of myself and look back, I think that I would have, I think that cone beam would have been so much easier for me to learn and pick up if I had had a robotic platform at that time, because I wasn't just learning cone beam, I was learning about stability and I was learning about how to, what kind of scope I want to use. Do I want to start with an MP, a tiny, ultra thin scope? Do I want to start with an extended working channel? How do I want to approach this? When I think the best thing when you're learning cone beam is to just be focusing on imaging, on your angles, adjusting your C-arm, and driving under augmented fluoroscopy. And the robot, I don't want to say training wheels, but it's a little bit sort of takes the focus off the other things that you have to pay attention to, and lets you really just focus on learning the fundamentals of cone beam. The robot is a relatively familiar technology now to more people. Using a controller, I think, is different companies have tried to make it as intuitive as possible, and I think makes it a lot easier to. I think robot makes it a lot easier to start learning cone beam CT. And then navigation is just familiar for anyone who's used any other navigational platforms. They all sort of present the same way on the user end or present a similar way that I think makes it a little easier to pick up.
Great, thanks so much. Dr. Manley, did you want to maybe talk about your experience with learning curve and robotics?
Yeah, sure. So we got our spin, so we use a CO spin. We got it probably three or 4 years into our robotic program. So I was pretty comfortable with the robot and then added the spin. And I think the biggest thing that I would tell people is don't try and figure out your correction all at once. You do your spin, they give you an axial, coronal, and sagittal, and you see yourself not in line with the nodule. And people will try and go, okay, I need to correct in this direction. I'm trying to do it all at once. And what I did was I just asked myself 3 simple questions. Is it anterior or posterior to the lesion? Okay, I know I need to go posterior. Is it medial or lateral? Okay, a little posterior, a little medial. Okay, is it superior or inferior? And then it's almost like playing the game like Battleship. You have like a sort of a grid of your correction. And then I would go back to the controller and be like, okay, which way is superior? Which way is medial? Which way is anterior? Which way is posterior? And then I would sort of make my corrections in a really meaningful way. And what I see some people do sometimes is they'll do a spin and then they'll try and make a correction and the robot's moving it's moving opposite to what they wanted it, where they wanted it to go. And I think it's just because it's hard to do this sort of three-dimensional problem solving, and you have to take it easy on yourself. So break it down into sort of the components and do them one step at a time. Be sort of meaningful about your movements. Recheck with your fluoro, doing fluoro spots. Keep your CT scan up so you've got your coronal view of your actual CT scan you can scroll through, and your axials and things. And kind of give yourself a break, because you really are translating something from multiple screens. You've got your EM picture, you've got your robotic overlay, you've got your spins, you've got your radial ultrasound, your 2D spots, and you're trying to conceptualize all of it at once, and really no one can keep that inside their brain. You have to just break it down into very simple component pieces. And once you give yourself a break and do that, I think it comes together pretty nicely.
Great, thanks so much. The battleship analogy was appreciated. Emily, would you like to close us off for the evening? I know we're nearing time for completion tonight.
Yes, so thank you everyone for joining tonight's webinar. We appreciate it, and obviously we appreciate our sponsors, Ethicon, for this webinar as well. Thank you, Drs. Manley and Dr. Schaller, for a wonderful, informative presentation, and we look forward to seeing you all at more SAB webinars.
Thank you.
Thank you.
Thank you.